Hello everyone. Today, let us learn about an important topic known as subtrochanteric fractures. So, subtrochanteric fracture of femur contributes about 10 to 30% of all hip fractures. You can see that they'll have bimodal peak of distribution, 20 to 40 years of age group and more than 60 years. So, here this is an X-ray pelvis with both hips showing subtrochanteric fracture which is present here. Also, here in this picture you can see that this is the subtrochanteric area which is present below the intertrochanteric region. It is present 5 centimeters distal to lesser trochanter. Now let us learn about the anatomy. So what is subtrochanteric fracture? So it is a fracture between lesser trochanter and up at a point 5 centimeters distal to lesser trochanter. The subtrochanteric part of the femur is subjected to high biomechanical stress. Medial and posteromedial cortices are the sites of high compressive forces. Lateral cortex is the site of high tensile forces. So this is the medial cortex and this is the lateral cortex. The medial cortex is subjected to high compressive forces and the lateral cortex is subjected to high tensile forces. Okay, so the subtrochanteric area consists of large amount of cortical bone. So the vascularity is less when compared to that of intertrochanteric fractures. Hence, the healing potential is less when compared to intertrochanteric fractures. Next comes is deforming forces. So for the deforming forces, here in this picture you can see, this is the proximal fragment. This is the distal fragment. The proximal fragment goes into abduction and external rotation. Abduction is by gluteus muscles. Then external rotation is by short rotators. And it goes into flexion with the help of iliopsoas. Okay, and this is the distal fragment which goes into varus with the help of adductors. So as we have already learned about the deforming forces, so on the proximal fragment, abduction is by gluteus medius, external rotation is by short rotators, flexion is by iliopsoas. Distal fragment is pulled proximally into varus by adductors. Next comes this mechanism of action. So they are two mechanisms of injury: low energy mechanisms, high energy mechanisms. Low energy mechanisms even usually seen in old age people, even because of a simple minor fall, also usually because of their osteoporotic bone, subtrochanteric fractures can occur. In high energy mechanisms, most commonly seen is through RTA or gunshot wounds. Next comes is pathological fractures. Pathological fractures is a frequent site. Subtrochanteric region is a common site for pathological fractures. Next comes is atypical fractures, usually seen in minimal or no trauma. Typically non-comminuted or minimally comminuted. Commonly seen with people using medications like bisphosphonates, glucocorticoids and proton pump inhibitors. Next comes is clinical features. So in the clinical features you have to remember is hip motion is painful. Swelling is present in proximal thigh region. On palpation you can see that patient is having tenderness in the proximal thigh region. Careful examination for the soft tissue compromise or if any open injury is present has to be seen. Severe blood loss can happen. Patient can go into hypovolemic shock. So you should always monitor blood pressure as well as heart rate. If there is any splinting which is present externally, it should be removed and it should be converted into scalping traction until definitive management is confirmed. Next comes is radiographs. In radiographs, compulsory we have to take pelvis with both hips AP view. And also affected limb, hip with thigh, AP view and lateral view has to be taken. Along with this, contralateral normal femur, a normal thigh also has to be taken in order to check the femoral length. We have to check whether if any shortening is present or no. So next comes is classification for subtrochanteric fractures. So the classification for subtrochanteric fractures is Rizal-Taylor's classification. So in this Rizal-Taylor's classification, as you can see in this picture, this is the classification is divided into two types, type 1, type 2. It is for in type 1, this is the greater trochanter and here you can see this is the piriformis fossa. So what happens is this classification is based depending upon the piriformis fossa. So if the piriformis fossa is intact, it is type 1. If the piriformis fossa is also involved, it is type 2. So when the piriformis fossa is intact, if it is type 1, it is further divided into 1A, 1B. In 1A, you can see that the lesser trochanter is in contact with the proximal fragment. Here, you can see in 1B that the lesser trochanter is detached from the proximal fragment. In type 2, it is further divided into 2A and 2B. In type 2A, posteromedial cortex is involved. In type 2B, you can see that the comminution is extending into piriformis fossa and also into the lesser trochanter. So that is Rizal-Taylor's classification. So as we already read, in type 1, fracture is with intact piriformis fossa is further divided into 1A, 1B. In 1A, lesser trochanter is attached to proximal fragment. In 1B, lesser trochanter is detached from the proximal fragment. In type 2, fracture extending into piriformis fossa. So it is further again divided into 2A, 2B. In 2A, have a stable medial cortex. In 2B, comminution of the piriformis fossa and lesser trochanter and is also seen. Next comes as treatment option. So treatment options, they are divided into 2 types. First commonly used is intramedullary nailing. Nails are of 2 generations. First generation, second generation. First generation nails are centromedullary nails. Second generation nails are cephalomedullary nails. So basically first generation nails, centromedullary nails are indicated when both for subtrochanteric fractures, when both the trochanters are involved. When both greater trochanter and lesser trochanter, both of them are intact, you can use a centromedullary nail. Second generation nails are cephalomedullary nails, usually used when there is loss of posteromedial cortex, can be used for fracture extending into piriformis fossa. And while inserting a nail, care must be taken for these 2 steps. So you should always see that when you are passing the nail through the femur, you should see how the nail is exiting out of the proximal fragment. And you should also keep in mind that the proximal fragment can go into varus or flexion, so care must be taken. Distally, anterior perforation can also occur due to mismatch between radius of curvature of the nail and the femur, as sometimes mismatch can happen between the radius curvature of the nail as well as the femur. Second option is 95 degrees fixed angle device. So this is the 95 degrees fixed angle device. So in this device, this is commonly used when both the trochanters are involved, both greater trochanter and lesser trochanter. If both of them are involved, you can use this 95 degrees fixed angle device. You will always add an additional proximal screw. As you can see below this plate, there is an additional proximal screw which is added into the calcar. This will increase the proximal fragment fixation. Okay, so next better option than this 95 degrees fixed angle device is the dynamic condylar screw. Other ones which can be used are proximal femur, pre-contoured locking plates. Okay, sliding hip screw is never used in subtrochanteric fractures. It is always a poor choice. Next comes is open subtrochanteric fractures. Open subtrochanteric fractures are often associated either with penetrating injury or high energy traumas, usually like RTAs. So in such cases, what we have to do is surgical debridement with osseous stabilization. Next comes is complications of the subtrochanteric fractures. So complications of subtrochanteric fractures include loss of fixation, non-union as well as malunion. I hope you like the video. Enjoy. Take care. Bye-bye.